today I'll be speaking about implantation and endometrial receptivity. This is a very dry topic, so just try to listen whatever I am saying. Ah. So human implantation is a complex process. So successful implantation, it requires, we all know, healthy embryo as well as receptive endometrium, and a synchronicity should be there between the embryo as well as the endometrium, and immune protection should be there from the host. So this is also important. So endometrium is a dynamic tissue which undergoes multiple changes during the menstrual cycle in response to hormones, which helps in creating a receptive environment. So there will be many secretions like autocrine secretions, endocrine secretions, paracrine secretions, which control the gene expression of the different endometrium cell types. So two hormones play important role, estrogen, progesterone. The proliferative phase, which is controlled by estrogen, allows for the proliferation of cells and glands, as well as the elongation of arteries. Whereas post-ovulatory progesterone raise brings about secretory changes, and the endometrium acquires a receptive phenotype permitting implantation. So this period of receptivity is known as the window of implantation. So this is for successful implantation to happen, there should be a competent embryo, blastocyst, and there should be a synchrony between both embryo endometrium and receptive endometrium. So all these factors will be playing a role, and then embryo maternal signaling should be there, and then followed by successful implantation. So pre-implantation embryo development, when a lady has 28 days cycle, LH surge will be around day 14, then ovulation will happen on day 15, whereas fertilization happens on day 16, 17, and then there will be morula on the day 18, 19, 20, whereas implantation process will start on day 21 or day 22. So embryonic genome activation will be there. So from day 3 to day 5, it has to be the embryon. Because of embryonic genome activation only, the embryo will grow from day 3 to day 5. So growth till morula stage, then compaction of morula into blastocyst. So zygote starts a 4 to 5 day journey from the ampulla portion of the fallopian tube towards the uterus, developing into the morula stage by an increase in cell number. Whereas the overall amount of cytoplasm in the embryo remains constant, the number of nuclei and DNA increase exponentially. And also this mRNA and proteins are maternally driven, and embryonic genome is activated, which happens during the 4 to 8 cell stage in humans. So this implantation period is a short self-limited period in which the endometrial tissue acquires a functional and transient status that permits blastocyst adhesion and is therefore receptive. So this specific period is regulated by ovarian steroid hormones and genetic factors. So window of implantation, it roughly lasts for around 30 to 36 hours depending upon the patient. It can occur if you are seeing a natural cycle when LH surge plus 6 to LH plus 9 in natural cycles, or if we are doing a HRT cycles from the day of starting progesterone plus 4 to P plus 7 in HRT cycles. So endometrium undergoes all these changes like morphology, cytoskeletal, biochemical, genetic changes to become functionally competent. So this is the diagram showing window of implantation from LH plus 6 to LH plus 9, 30 to 36 hours. So then what is endometrial receptivity? It is defined as a period of endometrial maturation during which trophectoderm of the blastocyst can attach to the endometrial epithelial cells and subsequently proceed to invade the stroma and vasculature. So ovarian hormones regulate the development and receptivity. So endometrium is divided into functionalis and basalis layer. So basalis layer is constant. It is attached to the myometrium. And whereas functionalis layer is composed of a layer of epithelial cells on the surface overlaying the glands and stroma, which consists of like extracellular matrix, blood vessels, and immune cells. So this is the summary, like what are the estrogen actions, progesterone actions, like endometrial proliferation, then upregulation of progesterone receptors, then all this upregulation of this VEGF, L-selectin, all these factors which help in implantation, and then progesterone secretory luteal phase, morphology changes, penopod formation, then upregulation of this VEGF, all these factors, and then downregulation of estrogen activity. So successful implantation, it is like a uterus embryonic crosstalk should be there, and there should be signaling between the endometrium and blastocyst. It happens with specific steps such as apposition, adhesion, and penetration. So what is apposition? Just the initial contact of trophoblastic tissue to the epithelium of the endometrium. Then adhesion requires an increase in vascular permeability into the endometrium. So then the final stage, penetration, involves invasion through the luminal epithelium into the stroma, connecting to blood supply, and then commencing endometrial destigmalization. So this is the like apposition, adhesion, attachment, and invasion, penetration. So during this apposition stage, it is unstable adhesion. So this mucin, through the mucin flow, MUC flow, which is continuous towards the cervix, once embryo reaches into the endometrium, then apposition is progressively increased between the trophoblast and epithelium, which is characterized by enlargement of embryo, then edema of the endometrium, decrease in the uterine fluid volume, then the obliteration of the lumen by apposition of endometrial and trophoblastic cells, and appearance of penopods. So all these mediators help, like MUC1, chemokines. Then rolling over is blastocyst enters the uterus and then rolls over into the endometrium. This L-selectin ligands will be there. So all this will help L-selectin integrins. Then adhesion. Adhesion is like direct contact between the epithelium and trophectoderm. So it is seen like implantation on day 20 to 21 in humans. So increased permeability, vascular permeability will be there. So the endometrium and embryo now express extracellular matrix component. So integrins, selectins, all this heparin binding growth factor, all these cathedrins, immunoglobulins, all this will play a role in adhesion. So invasion, three types of interactions, like between trophoblast and epithelium. Like trophectoderm cell migrate between the epithelial cells and then penetrates as far as the basement membrane. Then epithelial cells lift off the basement membrane. Then there will be the fusion of trophoblast with epithelial cells. So VEGF, collagenases, plasminogen activator, because it has to disrupt the endometrial layers and go, all this will play a role. So this is a blastocyst invasion aided by dissolution of E-cathedrin. This is the same thing how human embryo is attached, like because of MUC1, L-selectin, this chemokine receptors, then adhesion molecules are integrins, cathedrins. So invasion, this FAC ligands will help, matrix metalloproteinases, all this will help in this uh, attachment process. So embryo will secrete certain things, and then endometrium will secrete certain things along with ovarian hormones. So all these help in the attachment like implantation process. So growth factors like TGF beta, which have a role in implantation. So this inhibin A, activin A, this modulates immune tolerance. So signaling associated with onset of uterine receptivity, attachment, VEGF. This is the major modulator of vascular growth, remodeling, increases the vascular permeability. And also HCG classic signal. So this is also important. So this HCG secretion is regulated by GnRH. So the early blastocyst also synthesizes some amount of GnRH. So this GnRH in turn synthesizes this HCG mRNA. So this thing is detectable as early as in the 2-cell stage in the embryo, and detectable concentrations of HCG are already produced before implantation. So before the implantation, that's why what we do is sometimes we give HCG flush, this thing before doing embryo transfer, like after starting gestone also will give the HCG flush. Why? Because this also can help in the implantation, because early embryo like 2-cell stage embryo also produces this HCG mRNA. So the critical days of the establishment of pregnancy are day 6 to day 10 after the LH peak, which relates to the time of increasing HCG plasma concentrations. So what does this HCG do? Embryonic action via HCG on the endometrium is through indirect effect. So it does indirect endocrine effect via rescue of corpus luteum and subsequent progestogen release, and then direct paracrine effect on the endometrium. And then this luteotropic activity of the HCG, this progestogen controls the endometrial function by increasing this leukemia inhibiting factor, all this secretion which originates from T cells. So blastocyst, this is the early blastocyst also secretes some amount of GnRH, which in turn, because this has GnRH, it secretes HCG, which has a indirect effect on the corpus luteum, which produces progestogen, and then this progestogen again acts on the endometrium. So HCG acts directly on the endometrium and indirectly also by producing progesterone. So this is the thing. Embryo, endometrium, ovary, uh, how invasion happens because of all these factors. So effects of HCG shown synoptically in 3 compartments, like in the embryo also, on the endometrium also, and ovary, finally influencing endometrial differentiation, decidualization, and embryonic invasion. So several genes have been identified as playing a role in endometrial receptivity. So many genes are there. One of the important genes are like HOX genes, specifically HOXA10 and HOXA11. They have demonstrated increased expression in the secretory phases, correlating with increased estradiol and progestogen levels. So this HOX genes, they also regulate the expression of other genes. So pinopods are also important for attachment. So all these pinopods, integrins, this insulin growth factor. So all this genes will regulate the expression. Then numerous cytokines, growth factors, they are all associated with receptivity and implantation. Leukemia inhibiting factor, this heparin binding growth factor, integrins, mucin 1, WNT signaling, and beta catenin proteins. So leukemia inhibiting factor regulates trophoblast cell adhesion, and it is important for embryo invasion and placental development. So integrins, they're all associated with embryo endometrium communication. So this integrin like alpha V beta 3 is also increased by HOX genes during the window of implantation. and demonstrates decreased levels in conditions such as endometriosis. So another potential mediator of implantation is this mucin 1, which is downregulated by the blastocyst. So mucin 1 is increased during the follicular phase, whereas not that much increased during the luteal phase. And also this uterine WNT signaling, it is also important at the time of embryo attachment. So all these proteins like cysteine-rich molecules, which are WNT proteins, they all play a role in implantation. And then, so all these factors are playing a role. Then mother's immune system also should accept the pregnancy. So placenta plays a crucial role of establishing intimate contact of fetus with maternal uterine tissue. So the trophoblast cells are the most important fetal cells coming in contact with the maternal cells. So if you see, these are the villi, then syncytial trophoblast, then extravillous trophoblast. These come in contact with the decidua. So this trophoblastic tissue is the first point of contact of the baby to the endometrium. So this immune system is first recognized that immune tolerance in pregnancy, Medawars hypothesis in 1953. So when the concept of fetal allograft was presented, he suggest he suggested that the fetus escapes rejection between the immunological interaction between the mother and fetus. It is suppressed. So he proposed that this was due to a lack of fetal antigen expression resulting from an anatomical separation between the mother and the fetus, or from functional suppression of maternal lymphocytes. So peripheral immune system like T cells, NK cells, monocytes, granulocytes, dendritic cells, then immune system in decidua like uterine NK cells, decidual T cells, macrophages, all this will help. So effect of pregnancy on immune system. This peripheral immune system, so mechanism to escape rejection by the fetus. So fetus has to escape this thing, immune system. That is major histocompatibility complex. MHC expression will be there. That class 1 expression will be there by trophoblast. Then uterine modulators by means of haptoglobulin, uteroglobulin. Then there will be down regulation of T cell activity. All this will happen during pregnancy. So how pregnancy affects immune? Mute your this thing, no? So there is increase in the peripheral WBC count. It is the first recognized change. So we all know that pregnancy is a Th2 phenomenon. So Th1 produces gamma, TNF alpha and interleukin 2, which promote cellular immune responses. Whereas all this interleukin 4, 5, 9, 10, they promote humoral responses. So there will be decreased ratio of this Th1 and Th2. So pregnancy is more of Th2 type. What does this decreased ratio of Th1 to Th2 cytokines do? There will be induction of progesterone-induced blocking factor in leukocytes. Trophoblast produce mainly Th2 cytokines, and then this thing, indolemine 2,3 deoxygenase, this villus syncytial trophoblast will express this. This causes catabolism, and this indirectly suppresses the maternal T cell activity. So what will happen whenever fetus with paternal antigens comes? There is decreased natural killer cell activity with decreased Th1's response and increased T helper cell response with progesterone, this blocking factor with protective cytokines, no activation of complement cascade, and there will be fetal protection. So although the uterine NK cells are present in the decidua, they do not attack the fetus. This is due to the fact that uterine NK cells, they express inhibitory receptors. So mainly fetus will have this MHC class 1A human leukocyte antigen complex will be there on the trophoblast like HLE, C, E and G on the trophoblast, and then they bind to this MHC1 antigens. And then this MHC class 1B, there it has a role in immunoacceptance of the fetus. So all these things are there, like killer immunoglobulin receptor. So all this will happen in pregnancy. So this trophoblast has got only HLA class 1 like CGE. There is no HLA class 2. So this will interact with inhibitory receptors. So macrophage, all this. So they produce immunosuppressive factors. And then there is inactivation of T cells. All this will happen like protective mechanism in pregnancy. So the present observation suggests that at the maternal and fetal interface, a balanced production of cytokines by various immune cells like T lymphocytes, NK cells, macrophages is needed for a successful pregnancy. So which in turn suggests the existence of a complex fine-tuning system for cytokine production. So now this thing for implantation to happen, there should be a proper immune acceptance in the pregnancy. Then are there any markers for endometrial receptivity? So diagnosis of endometrial receptivity has posed a challenge because there are no any accurate markers or clinical predictability tests for endometrial receptivity. So various like biochemical, molecular have been proposed. Then histological markers. So this histological markers method was first proposed by Noyes. So for morphological criteria to evaluate when the endometrium is receptive. So for many decades, this remained the mainstay. The use of Noyes criteria to predict the window of implantation accurately has been questioned because this is a very tedious thing, like dating the endometrium based on this nuclei, vacuolation, secretion, gland mitosis. So all,
లిఫ్ట్ చేయట్లేదు.
you can mute your microphone, no?
ఇక్కడ అడగమనమ్మా, అక్కడికి వచ్చారని శ్రీకి ఫోన్ చేసి కనుక్కోమను. శ్రీ
You can
వాళ్ళకి పేషెంట్ నంబర్ లేదా?
you can mute your
పేషెంట్ ఫోన్ లేదా?
microphone, no, doctor. So because the tedious process, so and this could then next penopods. So endopods, they also generated little interest in the 70s, 80s. So these penopods are like cytoplasmic projections of the endometrial epithelial cells abundant during the window of implantation for blastocyst adhesion. So they can only be visualized with the electron microscope. Their appearance is cycle dependent and seems to be under progesterone control. So by assessing these penopods, they have shown that this window of implantation is open for less than 48 hours. So, however, quantification of penopods, this is highly subjective. So again, there are many penopods. So most studies fail to show there is no reliable pattern for the expression of penopods. So again, their significance as markers is unproven. Then biochemical markers. So a number of molecules present during the mid-secretory phase have been studied. The ones which have shown significant association are like integrins, leukemia inhibiting factors, homeobox genes, mucin, all these things. Many more are being investigated. So none has been found to have a place in the clinical setting. So again, this is the summary of the endometrial receptivity biomarkers. All this thing, integrins, calcitonin, leukemia inhibiting factors. So any molecular markers are there. The various molecular approaches for the study of biological samples is collectively called the omics and include genomics is study of genes, like transcriptomics is the study of gene expression. So now currently transcriptomics, that means how is the gene expression during the receptive phase. It is considered the most established technology available for the evaluation of the endometrial factor. Then transcriptomics of the human endometrium. The transcriptome reflects genes that are actively expressed at any given time within a specific cell population or tissue. So it allows characterization of gene expression at the MRI level, giving rise to a sample specific molecular profile or transcriptomic signature. So analysis of transcriptomic profiles is done. The transcriptome of the endometrium has been defined in all phases of the menstrual cycle. Clustering of genes into 4 groups was identified, like proliferative, early secretory, mid secretory, or late secretory. So again, human endometrium transcriptome, it has been studied in the natural cycle, whereas during ovarian stimulation and HRT cycles, then in recurrent implantation failure, whereas women who has endometriosis or cancers, endometritis, all this has been studied. So at a molecular level, pre-receptive or early secretory phase is characterized by increased metabolic activity in the preparation for implantation. So what will happen during this pre-receptive phase? There will be a predominance of all this cell metabolism products like fatty acids, amino acids, everything. And then an increase in the metabolism is consistent with the fact that this phase is highly active. So which probably represents tissue preparation for embryo implantation. So inhibition of mitosis during this phase. So receptive phase witnesses a transcriptional awakening or upregulation of most gene expression. Apart from a high level of metabolic and secretory activity, there is an upregulation of genes involved in the activation of immune response stress. So genes whose expression changes during the transition between the early and mid secretory are potential candidates for regulation by progesterone. So whenever we do a ERA like endometrial receptivity array, so we'll get like whether it is a proliferative endometrium or pre-receptive endometrium, receptive endometrium, or post-receptive endometrium. So what all will happen during this proliferative function, this early secretory phase, mid secretory, and late secretory phase? So this transcriptomics of endometrial receptivity, no, they have done a study 15 years. So how in the fertile women it is characterized, because fertile women, how they are taken is patients were egg donors. That means there is no problem. It was not like self cycles. So with no disease, nothing, no inflammation. Then again, they have studied the infertile women who had a history of repeated implantation failure. All this. So then how are the transcriptomics of fertile women? So only 2 genes were common in the natural cycle, that is osteopontin, a glycoprotein involved in cellular adhesion and migration, and interleukin protein 15. This cytokine seems to be involved in stages immediately before and during the apposition step. So again in 2009, there was a transcriptomic signature of around 1012 genes. Then again, they have simplified this. In order to develop a diagnostic tool for human endometrial receptivity assessment, then the authors have selected the 11 most upregulated genes which are predictive for a receptive endometrial status. So this diagnostic tool, which is called the WIN test, was the first to be commercialized. Then later, they identified 238 genes shown to be differentially expressed in the transition from early to the mid-secretory phase. So whenever we are doing ERA, they will study all these 238 genes and then they give the report. based on the specific transcriptomic profile during the window of implantation of fertile women. So these characteristic profiles suggest that a unique transcriptional process occurs to achieve a receptive endometrial phenotype. So again, in the stimulated cycles, what will happen to this ER transcriptomics? Again, there is a change in the profile of the receptive endometrium. Then this stimulation induced a functional genomics delay of the receptive endometrium. This can be due to increased gonadotropin dose or agonist cycle, antagonist cycle, whatever it may be. So it again affects the this endometrial receptivity transcriptomics. So again, whatever protocols we might be using, that also can affect the endometrial receptivity. So in infertile women, they have detected a substantial number of dysregulated genes in the endometrium of infertile women, so which are involved in transport. They showed dysregulation of pathways in lipid metabolism, all these things they have showed. So they demonstrated that natural cycles are associated with a better endometrial receptivity than stimulated cycles. Stimulated cycles seem to have a stronger negative effect on gene expression implicated in crucial pathways of receptivity. So using the ERA prediction tool, they displacement of window of implantation is more frequent in RIF patients, both in stimulated or natural cycles than in fertile women. Overall, in natural or stimulated cycles, transcriptomic modification of the endometrium occurs in RIF patients during the window of implantation, which could be due to displacement of the window of implantation. So, what will happen this during in RIF, there is a like asynchronous and pathological windows of implantation. So RIF was clinically designated by the absence of implantation after 4 or more transfers of 5 quality embryos, or after the placement of 10 or more embryos in multiple transfers. So different definitions are there. So this ERA contains 238 genes that are differentially expressed. Then this gene signature used by the predictor was obtained by selecting those genes whose expression was consistent. So they used natural cycles as the optimal model. So whenever we do ERA, we get an endometrium as receptive endometrium or non-receptive endometrium. So receptive endometrium means how we do ERA. First, like if a patient, usually in a RIF patient, like recurrent implantation failure patient, even when we are this thing transferring, whenever we are transferring a euploid embryo also, if patient is not becoming pregnant, then only we can do IRA. We can't, before ruling out the embryo factors, there is no need to do IRA, because first we have to know that genetically normal embryo only we are putting. Then also if it is not getting implanted, then only we can go for IRA. So IRA, like how we do is in a HRT cycle, like we can mimic whatever like estrogen, whatever we are giving, like a transfer HRT cycle, we can mimic. Like before doing transfer cycle, one cycle prior, we can do the IRA, like with same medicines and all. So instead of putting a embryo after starting gestone injection, we can take the ERA biopsy. So whenever we take the endometrial sample, the report will come as receptive or non-receptive. If it comes as a receptive endometrium, there is no problem. Then next cycle, we can directly transfer during that receptive phase. If the report comes as non-receptive ERA, it is further classified as pre-receptive or post-receptive, giving an exact status of the endometrium at the time of biopsy. So its sensitivity is good, but specificity is low. So ERA is more accurate than this histological dating, which we said as noise criteria and all, and is a highly reproducible method. So once we have done ERA, then that is applicable for around almost 3 years. They are telling up to 40 months after first diagnosing the personalized window of implantation. So again, they have compared the accuracy and reproducibility of this ERA versus histological methods. So ERA reproducibility was tested and its gene expression was visualized. So the reproducibility, according to them, the reproducibility of the ERA was 100% consistent. That means whenever we do ERA, it won't change for again cycle by cycle. So once we have done ERA, the same thing we can apply it for around 3 years. Then again, no need to repeat the ERA biopsy for the patient. So ERA is indicated for RIF patients since they are at a higher risk of having a displaced WI. Therefore, this analysis could be beneficial for patients with two previous, mainly good quality embryos and also euploid embryos we have ruled out. In the case of an atrophic endometrium less than 6 mm, ERA can be performed as long as the endometrial appearance is consistent for all cycles for this patient. So timing of biopsy like HRT, estradiol will start from day 2. Then ultrasound assessment like between day 7 or day 10. So whenever, like whatever, however we are doing, whenever there is a trilaminar endometrium of more than 6 mm and when P4 is less than 1, then we should start that exogenous progesterone. And then after 5 days, instead of transferring an embryo, we take a biopsy and then see. So in natural cycle, how we calculate is detection of LH surge, that is ultrasound monitoring from day 10 to day 11. Then biopsy is taken 7 days after the LH surge. Then if we are doing a modified natural cycle, then give HCG either recombinant or urinary. Whenever follicle size is more than 17 mm, then the biopsy will be taken 7 days after giving trigger injection. So whenever we are doing a stimulated cycle, biopsy can be taken on the next natural or HRT cycle. So endometrial, this cryotubes, whatever we are sending biopsy, it should be labeled with the patient's initials, date of birth, date of biopsy. Then endometrial biopsies were collected from the uterine cavity with Pipel catheter. Then immediately after the sample is introduced into the cryotube, it is shaken for around 10 seconds. Then the amount of tissue should reach the white line on the cryotube. Then immediately the biopsy sample is placed in a fridge 4 to 8 degrees for at least 4 hours. Then the preserved sample can then be shipped at room temperature. Alternatively, the samples can be kept in the fridge for 3 weeks or frozen at minus 20 degrees until the moment of shipment. So in less than 5% of cases, there is risk like biopsy procedure will fail to obtain a sufficient quantity of tissue, requiring a new biopsy. In less than 1% of cases, ERA report can come as non-informative, where new biopsy is required. So previously, whenever they were doing ERA for genes, microarray PCR based techniques were used. Now since 2017, they are using this NGS based techniques. So it is like a personalized embryo transfer for the patient. So HRT cycle, standard window of implantation. So whether the endometrium is pre-receptive, receptive or post-receptive, whether it is displaced. So we'll be knowing. Receptive means gene expression is concordant with the receptive endometrium. Recommendation is to perform a blastocyst transfer following the same protocol and timings utilized during the ERA test. Then early receptive means the gene expression profile is concordant with the endometrium at the beginning of the receptive stage. So the recommendation is to administer progesterone for 12 more hours relative to when the biopsy was taken before performing the blastocyst transfer. Then if it is early receptive, you have to delay the transfer. Late receptive, then the gene expression profile is concordant with an endometrium at the end of the receptive stage. So the recommendation is to administer HRT for 12 hours less relative to when the biopsy was taken. So you have to prepone. So pre-receptive is gene expression profile is concordant with endometrium at a pre-receptive stage. This could be due to displacement of the implantation window. In around 5% of cases, you can, if it comes as pre-receptive or late receptive, again you can perform a repeat biopsy to see like this thing before 12 hours. Late receptive means after 12 hours to confirm that whatever we are doing is falling in the receptive phase. So it can also come as proliferative endometrium. So the gene expression profile is concordant with endometrium at a proliferative stage. It is recommended to contact the ERA lab to evaluate the protocol in which the biopsy was performed. So again, whenever we are doing ERA test, receptive means we can do an embryo transfer. If it is like pre-receptive or post-receptive, again we can repeat the ERA test by 12 hours preponing or 12 hours postponing based on the receptivity. Then again, later when it falls into the receptive endometrium, we can plan a embryo transfer. If it comes as proliferative, again we have to contact the lab. So limitations are like invasive nature, need for embryo 100% freeze-all cycles we should do, and cost. So this is like for personalized embryo transfer as a treatment for patients with RIF. So patients with 3 or more previous failed cycles of at least 4 good grade embryos, and then around 85 patients they have taken RIF patients. Then the results showed that a changed WI existed in 25%. In control, sera was non-receptive in only 12% patients. So this suggests that an endometrial factor exists in a quarter of patients with RIF and could contribute to their implantation failure. So therefore, it is like a personalized embryo transfer or transferring an embryo based on the women's personalized window of implantation. So correcting the WI by doing a PET improved the reproductive outcome. So these are some studies which favor ERA, like personalized embryo transfer helps in improving IVF or ICSI outcomes. So not all studies favor ERA. RIF, like whether there is role of PGT and ERA to optimize reproductive outcomes. So for some patients, they have done like both PGT and ERA, whereas for some patients, they have done only PGT, whereas for some patients, no PGT, no ERA. Even though they have done in group A both, the implantation rate was 53%. Only if PGTA was done, it was 47%. Without doing anything, implantation rate was around 42%. So PGTA and ERA for RIF do not seem to offer beneficial reproductive outcomes. So evaluation of the endometrial for aneuploidy, ERA and PGT for aneuploidy in overcoming RIF. So it is a retrospective patients who failed to achieve implantation following transfer of 3 or more or 5 or more embryos in at least 3 single embryo transfer. So moderate RIF is 3 or more failed, severe is 5 or more embryos failed. Conclusion is PGTA may be beneficial with higher implantation rate, ongoing pregnancy rate for patients with moderate, but not for severe cases. So at its current level of development, ERA does not appear to be clinically useful for patients with RIF. So this is the study again supporting the role of ERA in patients who have failed euploid transfers. So around 88 patients they have done between 14 and 17. Our experience demonstrates that a significant proportion of patients with a history of implantation failure of a euploid embryo have a displaced WI as detected by the ERA. For these patients, personalized transfer using a modified progestogen protocol may improve the outcomes of subsequent euploid. Larger trials are needed. So, according to some guidelines, this is just limited to research settings only. So adenomyosis also, it is a disorder characterized by the presence of endometrial glands. So there is failure of implantation in adenomyosis, which has been attributed to altered peristaltic activity, impaired receptivity, alterations in the crosstalk, and defective decidualization. So this endometrial receptivity studies have identified defects in specific genes like LIF, homeobox genes, integrins. So the role of immune system in implantation failure is widely accepted through the exact mechanisms involved. Then again, chronic endometritis. It is a chronic inflammatory condition. Then approximately 30 to 60% of infertile women with a history of RIF have endometritis. So we have to do CD138 staining for endometritis. So all this again a window of implantation that is impaired by chronic endometritis. It is again reversible after you treat the endometritis with appropriate antibiotics. So whenever there is chronic endometritis which modifies the WI leading to embryo endometrial asynchrony, it is not recommended to transfer embryos based on the window of implantation obtained by performing ERA in the presence of chronic endometritis. First, you treat chronic endometritis and then only do ERA testing. So is endometrial receptivity affected in women with endometriosis? So what this study has said is none of the 238 genes present in the ERA were significantly over or underexpressed in any of the different stages of the endometritis. So endometrial receptivity gene signature during the implantation window does not vary significantly among patients with endometritis, even considering different stages of endometritis compared with healthy women. That's what we see a lot of IVF pregnancies, even when a patient first cycle only, many will become positive, even though they have endometritis, endometriosis. So obesity, does it affect this endometrial receptivity by displacing WI? So obesity has a negative effect on endometrial receptivity through delaying of the window of implantation, which increases in function of BMI as well as the metabolic disturbances of the patient. So again, this ERA, how much it is reliable, because first we have to rule out that the embryo is euploid, then only if the repeated transfers are failing, we can consider ERA. So right now there is no strong this thing to support that ERA is beneficial. Again, it is emerging like transcriptomics in human endometrium. Okay, thank you. Anyone wants to ask anything? This is a very dry topic, I know, this thing. Because again, this immunology, reproductive immunology, this is again an emerging, evolving topic. So which none of us have a detail, have a at least rough knowledge. So we don't have proper knowledge. So at least I think some people are coming with courses on reproductive immunology. Our 49 also has started talks with some reproductive immunologists, and they have come up with some module courses. I think it might help us in understanding at least something about reproductive immunology, so that at least we can have some idea so what is happening. So it is still enigma, that RAF, whatever is happening, how much ever euploid embryo you transfer, 2 or 3, it might fail. So everything will be normal. Then again, we have to focus on immunology. So what is happening? So all these things are there. Okay, then thank you. Yeah, thank you. Bye.